Hello and welcome to Home Run Review. Today's quick series will go over OCD with a focus on the DSM-5 criteria of OCD and our secondary focus looking at relevant clinical information of this disorder. Okay, so there are four main criteria within the DSM-5 that outlines OCD, which is obsessive compulsive disorder. The first is having obsessions, compulsions, or both. The second being, are these obsessions, compulsions time consuming? Do they cause significant distress? These symptoms should not be because of another medical condition or any substance use. Fourth, and importantly, all of the symptoms here are not caused by another diagnosis. So this could be something physiological, such as a traumatic brain injury after a car accident, mental, such as schizophrenia, or once again, substance use. So now let's go ahead and look at these a little bit more in detail. Okay, so if this is the first time you're coming across OCD, you may be wondering what obsessions or compulsions are, or how these two things interact. The best way I can describe it, and the fastest way, is that obsessions are the thoughts that drive the compulsions. So obsessions could be something that are recurrent. These could be thoughts, urges. So think of hitting someone on the side of the street, right? That could cause significant distress. You would then need to have a compulsory action. So the action could be, for instance, you could rub your hands 3 times in a sequence to forget about that or to relieve the distress, is a better way to put it. Another thing you could do is have a mental game where you could pray 3 times or you could say 3 Hail Marys. But the thing is that you must do these things in order to get that negative thought out of your head. Um, so there are some things that we'll go over, but usually there is some sequential order to this, or there's some repetitive behavior. Another good example that I could give you is the classic person who washes their hands a lot, right? So in this instance, we would have someone who is afraid of germs. They could even realize this is an irrational fear to the point that their actions do not match up with their beliefs. However, they still obsess over germs, and in order to alleviate that obsession, they're going to have a compulsive action, which is to wash your hands repetitively, right, for a prolonged period of time. This will relieve some of that anxiety or distress. Now, is it possible to have an obsession without a compulsion, to have a compulsion without an obsession? The answer that you would be given on a test is going to be yes, you can have an obsession without a compulsion. You, however, are really not going to see this happen in real life, as it is ultra rare. Okay, so let's recap. What is an obsession? An obsession is something that you obsess about. A compulsion is something you do to alleviate that obsession. Okay, so now let's think about what makes this actually a disorder and not just something we all experience. Because we can all have that thought that comes in our head and we shake our body in response to it, right? Okay, so how do we actually meet criteria? Well, you're going to have an obsession, compulsion, or both for longer than 1 hour over a 24-hour cycle. And this is going to cause significant distress. So what do we mean by domain? Here we mean think work, think social life. Are you no longer able to spend time out with friends? Do you have an extreme interest in baseball and you can no longer go see those home runs? That would absolutely qualify as an impairment. So the next two we've really covered already. You're not going to want to diagnose someone with OCD if they're having these symptoms because of another medical condition or because they use a substance, such as, let's say, whenever they take methamphetamines, they have OCD-like symptoms. That would not meet the criteria for OCD. Let's say someone has schizophrenia, if they are pacing around and they're repetitively saying something that may at first look like OCD, especially if it's some ritualistic behavior. However, this would not classify as OCD because it is a different disorder causing these symptoms. Okay, so now that we've established the diagnostic criteria for OCD, we do have a couple of specifiers to go over, and I'll just break these down very quickly. I don't really see this as high yield, so I'm not going to go super in detail on this. Clearly, what you want to see here is that there are three, right? You have good, poor, or absent insight. If you have good insight, right, That means that you can recognize that the compulsions that you have don't necessarily align with a rational explanation for alleviating an obsession. Classically, we can just think of someone who's washing their hands in excess. They recognize that they don't need to do this in order to be hygienic. Uh, if someone does not recognize that at all, right? Maybe they believe they have to wash their hands for 1 hour before they're actually clean. Well, that's clearly absent insight or delusional beliefs. Then we're bordering alongside schizophrenia. We're getting very close to that. You would have to then check out, okay, do they have positive, negative symptoms associated with schizophrenia? Okay, and now let's say that it's somewhere in the middle. You get what we're going at. It's going to be poor insight, okay? The main thing that we're going to have to also now add in is this also related to a tic disorder? So in about 30% of cases, according to some studies, it's been shown that people with OCD, especially in men, are going to have some predicating tic-related presentation. Okay, just there's two things here now that I want to jump into about the prevalence of OCD. In the United States, we're seeing the range always go from about 1 to 2%. To stay safe, say just around 1%. In the world, it's about the same. We see about 1.2 to 1.8%, but you can go anywhere from 1 to 2%. If we jump down, we can now see that there is a differentiation between adulthood presentation and childhood presentation in both men and women. And that being the prevalence, there is going to be more OCD cases in women in adulthood when you're looking at a pediatric population and a child population as well. Ranging into adolescence, you're going to see more men than women being diagnosed with OCD. Okay, so now wrapping up, there is a sensory phenomena, so just to understand a little bit what's going on a little bit more with an OCD presentation, you're going to see someone have a just right or incompleteness sensory phenomena. What essentially is being said here is that someone has this feeling of either being incomplete before they complete the compulsion, right? So once you complete that element, you get a just right feeling. And that is not the case with every presentation, although it is the case with the majority of presentations, I think hovering around 60% of cases. It's also important to reiterate the fact that people with OCD have an increased likelihood of trying to avoid places, people, etc. So be careful on an exam or on some question that you may receive one day. If someone is trying to avoid a public place, right, your mind might jump to agoraphobia or something like that. Read the question carefully. Make sure that this person isn't experiencing any OCD-like symptoms, because one big factor for people with OCD is that they're going to both have a higher likelihood of having some anxiety disorder, but also their OCD could drive them to avoid places, their friends, and usual things that they used to enjoy, all to avoid either A, the obsession, or the need of the compulsion. Okay, so another thing I want to touch on is the genetic concordance rate and also the heritability of OCD. What makes OCD similar to something like major depressive disorder or schizophrenia is that we have been able to implicate a genetic component to it, right? So, someone who has a monozygotic twin is much more likely to have it compared to someone with a dizygotic twin. Okay, so another important thing to understand about the belief system of some people with OCD is that there is some dysfunction associated with that. Okay, so like what type of dysfunction? Many people have preconceived notions of threat. They may have higher reactivity, right? They may not tolerate uncertainty well, which may drive perfectionism. They may believe that their thoughts have way more weight than they actually do, right? So someone with OCD is more likely to have an anxiety disorder. In fact, the comorbidity rate is quite high, with a lifetime anxiety disorder prevalence of 75%. So people who suffer from OCD also are more likely to suffer from anxiety disorders, even more so than not, right? And then also with depressive or bipolar disorder. And with that, unipolar depression is more common than bipolar in this instance. but those are two big things to look out for.